This is Jason Chandler. We're going to start the discussion portion of the malignant heme. And so I'll just go around and I'm Jason Chandler. I'm from here in Memphis at the West Cancer Center. And we'll introduce all the other members of the panel. So going around from Kansas, Dr. Abdulraheem Yacoub, do you want to introduce yourself?
Hello, yes, I'm Yacoub. I'm an associate professor of medicine at the University of Kansas Cancer Center, and I specialize in myeloid disorders, MDS, MPN, and elderly acute leukemia. Thank you very much for the opportunity.
Yeah, thank you for coming. And then we have Neha Mehta Shah. She's up at WashU.
Hi, I'm Mehta Shah. I'm one of the lymphoma doctors at the Siteman Cancer Center at Washington University in St. Louis. Thank you for having me.
Thank you for coming. And then we have Carlos Bachier. He's from the Sarah Cannon Center for Blood Cancer.
Yeah, thank you. Thank you for having me. Carlos Bachier. I'm the director of cellular therapy here at the Sarah Cannon Center for Blood Cancers in Nashville.
So great. So we just had some great presentations just now going over different updates from ASH and disease types that seem to have some real changes in what the standard of care is. So we were hoping to kind of bring in everybody's expertise. And so what we'll do is start with a case that I'll begin with, and then we can get everyone's input on how they feel we should manage this patient. So I'll just read it out. We'll have a 66-year-old African-American male, has a history of hypertension and diabetes. He presented with left neck swelling, and on imaging, his PET showed disease above and below the diaphragm. It appeared there was no evidence of any marrow involvement. A biopsy did show diffuse large B-cell lymphoma. The tumor was CD20 positive, CD19 positive, CD10 negative, BCL6, and MUM1 positive, an ABC phenotype. And it was showing overexpression of c-MYC and BCL2, but normal FISH studies. So kind of, I guess you would say maybe a standard expected upfront diffuse large B-cell lymphoma with ABC phenotype. So Neha, how would you proceed in this situation?
Yeah, so I think, there's been multiple studies to try to look at ways to advance care for patients with diffuse large B-cell lymphoma. And sadly, most of these studies have been negative when we try to add another agent to CHOP-based therapy. So patients in the untreated setting, CHOP remains the standard therapy for diffuse large B-cell lymphoma. I think the exception to this are patients who have double hit phenotype, meaning they have rearrangements of the genes for MYC and the genes for with either BCL2 or BCL6 translocations. And at WashU, we now do that standardly for all patients. Every center, I think, and pathology department has a different algorithm of when to undergo that testing. But certainly we have patients who were not MYC overexpressing, who then who show double hit histology. And so we do that for everybody. And in those patients, we choose EPOCH chemotherapy, but the rest, we often will give R-CHOP-based therapy.
So what do you think of the data with like Revlimid up front and some of the mixed responses, so the R-squared?
Yeah, so that's a great question. The Revlimid data is very interesting. There were two studies, actually 3 studies that showed that the addition of lenalidomide or Revlimid adds to R-CHOP with regards to progression-free survival. There was another study, a confirmatory phase 3 study that was done and presented last year that was a negative study. Some of that we think it may be due to selection. We think that Revlimid is more active in the ABC phenotype or non-GCB phenotype, and the studies that have been done that ended up being negative were not selective. There are follow-on studies planned of newer versions of lenalidomide in setting with R-CHOP, but I think in the current setting, we tend not to give lenalidomide with R-CHOP-based therapy based on the phase 3 data that was presented last year.
Yeah, it's hard, and you look at that data and you think maybe, you were compromising the CHOP sometimes for dose reductions and like what's the lower dose, but yeah, I agree. Every time we've tried to make CHOP better, it seems like it's so far not been successful. Yeah. So
quick question, Neha. Just sorry to interrupt, Jason. So
yeah.
there used to be kind of in the past, at least in the cellular therapy and transplant world, that the double hit aggressive lymphomas would be considered for autologous transplant in first remission. I know that now with aggressive induction, the benefits of upfront autologous transplant, it's not viewed as as attractive. Just your views.
Yeah, no, thank you for asking that question. So I think, in not that long ago, I would say, even 3 years ago or so, we used to consider auto transplants in first remission for patients with aggressive lymphomas. Those included patients with double hit lymphomas particularly. But then there was a large retrospective study that was done and presented and then published. It was presented at ASH 3 years ago now, published 2 years ago, that showed that the consolidation with autologous transplant for patients who achieved a complete remission to their chemotherapy did not benefit those who got EPOC or R-EPOC-based chemotherapy in the double hit setting. So at this time, we give dose-adjusted R-EPOC and we don't consolidate with an auto transplant. There have been some data it's interesting you bring this up. There were 2 papers at ASH this past year that looked at the use of CNS prophylaxis. And when you look at that data, unfortunately, those studies were also negative. So that's a whole other can of worms of how that impacts clinical management, which I think is quite confusing, to be honest. But when they looked at those patients, one of the things that predicted for less risk of CNS relapse were those patients who did get a consolidative auto transplant. So that's leading us, internally at WashU to just very carefully look at that data, especially once it's published, because CNS relapse is certainly a very high morbidity for our patients and something we're very concerned about trying to prevent if there are ways to prevent it. I think the other major shift in the last 2 years was the advent of CAR T cells becoming standard of care. And in the past, there was only one curative option for patients, or essentially for patients who had relapsed diffuse large B-cell lymphoma. And now there are at least 2. And so I think that has also shifted people from swaying against doing auto transplants in first remission and saving that. But yet, I think yet to be fully determined if that should be thrown out. I don't think it should be.
And to follow up, since you brought it up, do you guys use intrathecal or do you do high-dose methotrexate for those that have really high risk for CNS relapse?
Yeah, so thanks for asking that question. So I think in patients who have a high risk of CNS relapse, we look at the data that was presented. The last author was by Carrie Savage from a couple of years ago, looking at the BCCA registry and looking at what the risk of relapse with CNS disease was. And they used basically the IPI, which most of us are familiar with. And then they added, if you had renal involvement, that you got a point. And if you had adrenal involvement, you got a point. And if you had more than 4 points, your risk of CNS involvement was quite high. In fact, if you had 5 points, it was close to 35% of CNS disease. And so in patients with high IPI, we had been considering giving high-dose methotrexate in that patient population. We have done it variably, to be honest. I think a little bit dependent on age and comorbidities and other factors. But the way that I think one of the ways that tends to work well was published by Jeremy Abramson, where they give high-dose methotrexate on alternating cycles starting after cycle 2. And so by then, hopefully patients have lesser disease burden from their lymphoma, usually have less effusions or edema related to their lymphoma as well, and then tolerate the methotrexate better. And so in that, they did 3 cycles of high-dose methotrexate alternating after cycles 2, 4, and 6. So that's been one approach that we've used. And I think there's a little bit of a gestalt for the patients I think are very high risk, like patients with testicular involvement, patients with renal and adrenal involvement. That's what we've been doing. For patients who seem like they're at somewhat high risk, so patients who have double hit disease, who have lower IPI, or patients who may not tolerate methotrexate at high doses, we do intrathecal therapy. And my personal method is doing it once per cycle. I know there's some people who very firmly believe in following what was originally done for IT methotrexate prophylaxis, which is twice per cycle starting cycle 2. So there's some variability. The data from ASH, were two large retrospective studies that were done close to 1,000 patients. And they looked back to see if patients got IT methotrexate or high-dose methotrexate or no methotrexate, was there actually a difference in CNS relapse? And there was not, especially when controlling for IPI. And so I think that leads to question whether high-dose methotrexate is certainly is good treatment for CNS disease, but is it good prophylactic treatment, or is there a role for that? I think that's still in question, and I think as those papers come to publication, they'll be looked at very carefully.
It is really amazing that you can fit it in between 2 cycles and their counts still recover. As long as they clear the methotrexate, they do fine to stay on track. So.
Yeah.
Okay, so this patient got R-CHOP. And after 6 cycles, it was an ABC phenotype. So the type that would tend to relapse, I think, more frequently. And after 2 years, the patient had progressive disease, again, above and below the diaphragm. He had a repeat biopsy, which showed a similar diffuse large B-cell lymphoma with no other abnormalities. This patient got R-GemOx for reinduction or and got a 50% response after 2 cycles, and then was referred for autologous stem cell transplant. So basically, I was going to kind of say this would be, Carlos, I didn't know if you want to speak on that in this situation. Neha mentioned a little bit about some studies are using CAR T maybe before in high risk or different populations. Is pretty much if they have chemo-responsive disease, are you still seeing auto transplant in this situation?
Yeah, with a progression-free survival of 2 years, the standard of care, I think, is still to consider those patients that have chemotherapy-sensitive disease that relapsed, an autologous stem cell transplant. Good old Parma trial feels like a million years ago. Showed that was better than chemotherapy. The Corral study identified risks of patients that relapsed early, and those did not do as well with autologous transplant. And then finally, to your question of CAR-T, so there are 2 trials that are still ongoing that have not been published: SUMA-7 and the Belinda trial, that are precisely evaluating this question on whether patients that relapse within the first year of achieving a remission are then randomized to salvage chemotherapy and an autologous stem cell transplant or commercial CAR-T. The Belinda trial is still ongoing. The SUMA-7 with Yescarta completed accrual, and data is maturing, and hopefully we'll learn about those studies in about a year or so.
So like right now, if they have chemosensitive, it's not really a standard to go to CAR-T, right? I mean, this is if CAR-T would be after you've relapsed after 2 lines. Is that?
Yeah. First, we can talk all day about the financial burden of commercial CAR-T. But the clinical trials were done on patients who had either primary refractory disease or had failed 2 lines of therapy, and so the data on these other studies, it's Belinda and SUMA-7, we'll hope to learn more. I have a personal bias and think that they're probably going to be positive studies, and that that CAR-T probably will be used in those patients, because the outcome of autologous transplant on those patients that relapse early or that fail initial therapy, it's not that great.
Yeah, because in the Rituxan era, that Coral study, I mean, it wasn't quite as good as it had been before, right?
Yeah, but they you're right. I mean, some of this, so it used 3 studies. The Coral study, it was data combined from 3 studies, 2 retrospective, 1 prospective. And so some of those were a little older, but even but it has been analyzed on patients that received rituximab, and the prognosis of the short interval still was prognostic when it came to transplant.
And Dr. Yacoub, we're going to get to you in a minute when we get to our.
I think I was going to ask a question, a follow-up question, if possible. So if all things were equal, and CAR T cells versus autologous stem cell transplant were both an option for patients at any setting. Which modality give you a better long-term quality of life and less long-term complications?
So we don't know because it's those studies are still have not been published. I mean, if it's on patients, which I guess this patient will get there eventually. If you failed autologous transplant or you have relapse refractory lymphoma, then the outcome of those patients, obviously you already want to transplant if you relapse or if you have chemotherapy refractory disease, those patients don't do well with autologous transplant.
And Neha, I was just going to ask, so I know like in mantle cell lymphoma, there is data for maintenance Rituxan after transplant, but so for diffuse large B-cell lymphoma, I know there were studies out there for different ones, maybe ibrutinib or different things. And so is there any kind of data to guide us in that situation?
Yeah, I think unfortunately it's a largely negative data to guide us. So there were studies of maintenance rituximab following R-CHOP-based therapy in the early days of rituximab that all showed that there wasn't a benefit to maintenance if you got rituximab-based therapy in the frontline setting, which has been the standard for a number of decades now. And then there have been studies of using ibrutinib in maintenance. There have been studies of using lenalidomide in maintenance. Most of these they've all been negative studies. And I think with the lenalidomide data, there might have been some improvement in PFS that was seen early on. But unfortunately, most of these patients can't tolerate lenalidomide long-term immediately after. And so they ended up having multiple dose reductions and came off of therapy, or the majority of them did. So there's an issue of tolerability. I think there's still room to talk about maintenance therapy, maybe not with these agents, but in the future, hopefully.
Good. Okay, so our patient she had 2 years. He had 2 years for his first remission, and then he had transplant and had another 2 years. Now he's 70 years of age. So after auto transplant, he relapsed. So he was referred for alternative treatments. Carlos, give me 1 second. Let me ask Dr. Neha, if you had to pick and you had to say the patient was not a candidate at this time for CAR T, we have so many drugs that are now FDA approved in this setting. How do you decide what you're going to pick for a patient that's not eligible for CAR T just because of age or comorbidity?
Yeah, I mean, I think you asked a really good question about what agents to pick. There's a number of options, right? So there are options of giving age combinations like polatuzumab with BR. There are options of giving Revlimid as a single agent or in combination with rituximab. There are options on clinical trials of using bispecific antibodies, which were a big highlight at ASH this past year. There are options of using other chemotherapy options as well. And so I have in patients who have ABC phenotype disease, these are the patients that seem to do better with Revlimid or based therapy. And so I consider giving Revlimid rituximab because I think even in older or frail patients, as many of you see with myeloma, you're able to get people safely through that therapy with success. In addition, polatuzumab BR showed a durable remissions in over 30% of patients, and all those patients were pretty much chemo refractory. So I think that was impressive, and we've had some very good clinical results using that as well. Our threshold to be able to use CAR T cells is we keep a relatively low bar in terms of patient status. So, many patients into their 70s are able to safely get CAR T cells without major complications. I'm sure others can comment to that. And I think the major issues have been patients who have significant heart disease and other comorbidities, but in those patients who have major other medical comorbidities, there are contraindications to multiple therapies or ways that other therapies need to be modulated. And here, of course, we often have clinical trial options, fortunately, for patients in this realm. And amongst those the ones we have currently, using the bispecific antibodies has been very exciting and promising, especially in the era of some of these therapies only requiring one hospitalization for monitoring or no hospitalizations for monitoring with low rates of CRS, which was the initial concern for this class of therapy. We've been quite pleased with considering that additionally in their therapeutic armamentarium.
So then we have, we have R squared, then you have polatuzumab, now we have tafasitamab, we have like targeting CD19. And it seems like the future is going to be like, well, CAR T or antibody drug conjugates or BiTEs. And so that it's going to be even harder to decide later. So Carlos, go ahead.
I would say, I think harder is in some ways it's harder because you have more options,
right,
but I think
exactly.
many of these patients, if they're being treated for the palliative intent, are going to move from one therapy to the other in reality. And so when I talk to patients about it as they really struggle making these decisions as a family, I try to emphasize that, this is the next option. And if we're going to know if this is working in 3 weeks or 2 months or some finite period of time, and then the next option could be this. And so in reality, if they're tolerating the therapy and they're responding, that's the goal, that's the the holy grail. And then if that's not happening, fortunately now we have more than one option for these patients.
Yeah, definitely. Okay, so Carlos, assuming the 70-year-old has a pretty good performance status and we wanted to send them for CAR T, how do you pick which CAR T product to use, and how do you balance, like, do you think there's one that's better than another? And another question I'll ask is it outpatient, inpatient? How is that being managed now?
Yeah, so good question. I think in this patient, the standard of care would be to consider them for CAR T therapy. And so now we have 3 approved CAR T cells, Kymriah, Yescarta, and Lysocell, with responses in the 60-70% range, and with about 40% of these patients being in remission now a couple of years after CAR T. And so, the usual toxicities, cytokine release syndrome and ICANS, cytopenias, and perhaps a high risk of infections because of hypogammaglobulinemia later on. And so note that, obviously there's no randomized study between any of these products, and they a little bit of a different strategy for each of the clinical trials that led to the approval of these drugs. So people sometimes have biases in terms of which one is better from a response rate standpoint. Clearly, Yescarta is associated with slightly higher risk of CRS and a grade of CRS, and so and it's earlier. It happens a little earlier after infusion. Kymriah and Lysocell seem to have a slightly lesser degree of CRS, and it happens a little later. And for that reason, most patients that receive Yescarta in the inpatient setting because the toxicities are a bit higher, and they happen earlier. And then if you are considering the outpatient, given that in the outpatient setting, Kymriah and now Lysocell. There's a clinical trial outreach with Lysocell that evaluated administration of this therapy in the outpatient setting and in non-university programs, and the response rate and the toxicity profiles were similar to Transplant, the study that led to the Lysocell approval, and outcomes were similar. And so, the question is always also, should these therapies be given in community settings? I still believe that these therapies should be given in programs that that have cellular therapy or stem cell transplant programs or components to their hospital system.
And so when these the T cells, like when they look, up to a year later, I know some of the ALL data looked at really prolonged persistence and these patients getting cured. Is the appearance that some of these patients have a flattening of the curve and a possible cure with persistence, or at least eradication of the lymphoma cells?
Yeah, it's a good question, and in the Zuma-1 study, they presented at ASH that yes, that a lot of these patients still have persistent a year, 2 years out, but there are a handful of patients that did not have persistence and were long-term survivors. So there's a large number of patients that will have persistent of disease, but it doesn't seem to be necessary for persistence to be present for patients to be cured or have long-term remissions.
Neha, what about you? When you're telling someone about a CAR T cell, are you talking about cures or are you just talking about progression-free survival?
Yeah, I mean, I think as you just heard, I think for patients who have not relapsed within the first 6 months, there's good data to show that they can have very long-term remissions. I tell them that the data for CAR T cells has been, a number of years, not a number of decades. But we certainly have people who remain in remission now 5+ years out, and so I think in large cell lymphoma, where 5 years from chemotherapy, we consider the risk of relapse to be the same as the general population. I think from CAR T cells, there's probably a number of people who will be cured. Whether that's between the 30 to 40% range is probably my best guess. But
that's great.
Yeah, and even not being a lymphoma doctor, I think Dr. Fred Locke and Joel McGurk presented the real life data for CAR T cell and very well presented data from ASH 2 years ago, and they had very consistent data of patients not on trials showing long-term PFS without with a flat curve at the tail of it. Very encouraging data.
That's great. Okay, so we'll move on to our next case. So Dr. Yacoub, you get to be involved in this one much more. But you added some good points here. Okay, so our next patient is a 72-year-old Caucasian female. She presented with a white blood cell count of 16, hemoglobin of 9, MCV of 105, platelets of 155. Looked for other causes, and there was no real other etiology for this. And a bone marrow biopsy showed cellularity of 60% with dysplasia in all 3 cell lines. She had 4% blasts and 20% ring sideroblasts. Normal karyotype, DNMT3A and SF3B1 mutation by next-gen sequencing. So, Dr. Yacoub, how would you proceed with this patient?
Yeah, so thank you very much. And this is a very lifelike case. This definitely rings a lot of bells. So, when a lot of patients in that age group present with cytopenia, it's an MDS suspect. And there's a lot of MDS lookalikes, and we would like to invest in the diagnosis to confirm that the histopathological and the clinical data and the molecular data all match. So again, that's always the step one, is confirming the diagnosis. And in this individual patient who's presenting with 3 lines dysplasia and clonal mutations that are consistent with MDS that actually explain the phenotype, having the SF3B1 mutation and the ring sideroblasts. So again, when all these data match with having the histopathological, molecular, and clinical data match, then it's really very confirmatory for the diagnosis of MDS, which is definitely in a step that people should not take lightly at making that diagnosis. And then to approach this patient, when we definitely have to set goals and directions for this patient, she is in the age where allogeneic stem cell transplantation can be entertained, and different institutions have more comfort levels with the age of 70 to 75. So this is something that would be explained to the patient up front, that this could be an option, and it's the only curative option for therapy. And patients might want to start that discussion earlier rather than later to have that as an option for the future.
This lady has an excellent performance status. She looks great.
Yes, exactly. So, and that's definitely, and the timing of when do you refer them for transplant is the day you make that diagnosis, because it takes time to get patients ready for transplant and get the transplant ready for the patient, and you want to invest in that process early on in their diagnosis. That being said, this represents a relatively lower risk disease, judging by the blast percentage and her blood counts, and her normal karyotype. So based on that, we also need to define what are the clinical needs for this patient. And the cytopenia that she has most pronounced is her anemia. And she's more likely to require anemia-directed therapy, rather than MDS-specific therapy at this time. And as we evaluate for secondary causes for iron deficiency, we usually have a threshold of 8.5 or less, or by the time of first transfusion to start therapy. And patients with this genetic phenotype are likely going to progress with anemia first. So that would be our focus of therapy on her.
So, and in this patient, her hemoglobin did drop down to the 8 range, and she was started on an ESA. Also, to go to your point, you know, we look for all the other issues. Does she drink alcohol? Is her B12 folate? You know, all the stuff like you were saying, kind of rule it out, make sure it's MDS. And then in those patients that I guess have, you know, lower erythro ESA levels or EPO levels, they would be the ones more likely to respond. Do you ever add on Neupogen for these patients? What's your kind of threshold for using Neupogen with the
again, it's been published, and it's actually a safe intervention to provide to use GCSF in patients uniquely in patients with low risk MDS who do not have increased blasts, and they're responding to EPO, but they could use a bit of improvement, or if they're neutropenic and neutropenia is a clinical concern. I don't use it for the many reasons that that confounding the progression to AML or high risk MDS and increasing bone marrow blasts. So I have not used that as a standard option for these patients, especially when there are alternative options, or if EPO is working as a single agent. With the modern prophylactic antimicrobials, chronic neutropenia and MDS is rarely a clinical problem. So that would be adequate if that's it.
Okay, so then this patient, and I think I would agree, and Carlos, you would too, if someone sent this patient to you and said, will you transplant them? I mean, you're like, what's your goal here, right? I mean, you're gonna.
You know, absolutely. And so the revised international prognostic scoring system is usually utilized to determine, you know, which patients you would think about considering for transplant. And so if you have high, or so it's low, intermediate, high, and very high risk. And so, you know, clearly if you if you have a high or very high and otherwise good performance status, and you have a donor, you know, those patients should be considered for transplant. Low risk, you don't, and intermediate, it's a little bit of you know, a little bit gray zone, where you use other criteria, transfusion dependency, other, you know, bad mutations. But clearly in this patient at this age, we just do conservative therapy.
Great. So, and like in this patient's situation, her hemoglobin did respond pretty well to Aranesp. It was up in the like 10 range, and she felt well. But about a year in, her anemia worsened again, and a repeat biopsy was performed. Now she had 3% blasts instead of 4, still had the ring sideroblasts. She still had the DNMT3A, SF3B, but now a RUNX1 mutation. And her hemoglobin dropped down to 6.5, and she was needing blood like every 3 weeks. I'll just mention from my perspective, since it was a little bit of my presentation, this would be a candidate for luspatercept, which is one of the patients still kind of in that low risk group with the SF3B1 mutation, low blast percentage, but starting to need blood transfusions more often. And it's kind of like, what's your goal for the patient? Are you trying to palliate them? Or is there risk, like Carlos, you were saying, you know, is their IPSS high enough where you think they're going to succumb to AML in the near future? So what's that risk benefit decision, I guess? So I guess about this time is when, I don't know about you, Dr. Yacoub, if you would like send HLA typing just so that you have that and you know kind of what donor status is for these patients.
So exactly. So again, this is a patient who would have, again, in my clinic, would have been referred from the diagnosis. So that would be the year before that. And then at every event where their therapy needs to be modified. So for patients who are transplant eligible, which we at the beginning, we would assume this woman would be, they would also be getting serial bone marrow biopsies at a fixed interval. So every 6 months or so, as long as allogeneic stem cell transplantation is an option on the table, just because you don't want to miss that window when they have progressed too far or they're in acute leukemia by then, and then they will need bridging therapy or remission therapy before they go for transplant. So, and it was very appropriate that she actually had a repeat bone marrow biopsy upon her next event, just to confirm her disease status. She would be getting an allogeneic stem transplant evaluation at the beginning and at every disease event like this. Fortunately, I agree, and I agree with you, she did progress with anemia as expected with her disease, given her genetic genotype.
Mm-hmm.
And luspatercept, based on the medalist trials, is a very appropriate therapy, and she has a fair chance of responding to that for several years.
Okay, and so she did, and so now she's 74 years of age, and her blood counts are starting to drop. Her white counts 2, platelets of 35, hemoglobin of 7, neutrophil of 500. She gets another bone marrow biopsy. Now she has 15% blasts. She still has the DNMT3A, RUNX1, and now has a TP53 mutation. So she has 2 children. She has a 79-year-old sister who actually happens to match her. And there is an unrelated donor out there, a 30-year-old 10 out of 10 match. So let's just say, what would you do next? We talked a little bit about the new ways to treat these patients. So 15% blast, not quite full-blown leukemia, but how would you proceed with her?
So unfortunately, this is the natural course of clonal evolution. As patients, more time equals more disease progression and more clones showing up. So unfortunately, she's running the course of MDS. If we have a clinical trial for high-risk patients, she would be very much eligible given good performance status. Unfortunately, there are multiple national trials that are challenging the first-line therapy. At this time, the standard first-line therapy remains single-agent HMA. However, there are multiple agents in late phase 3 clinical trials like venetoclax, magrolimab, APR-246, pavadinostat. So many of those drugs we're expecting results soon at defining which of those drugs will make it to change the standard of care. At this time, the standard of care is single-agent HMA, and more recently, oral single-agent HMA as an option.
And I think that, the data definitely was very compelling for venetoclax plus HMA in this kind of high-risk MDS but you're right, it's all from phase 2 data with phase 3 pending. These are always seems to be the hardest. You can't quite call them leukemia yet. And, based on previous criteria, they may have been considered leukemia at one time, but now they're MDS. And so, you kind of expect them to progress, but so you would not add venetoclax to this right now.
I think in a compliant institution where we cannot really going through pathways, which seems to happen to be very much generalized in this world, we can't get venetoclax for this diagnosis of PURCLE. That's really in my institution without a diagnosis of acute myeloid leukemia.
And then Carlos, so like if you get this patient, what's our goal before we send them to you for transplant? What do you want? You're trying to get the blast percentage down, or what is our?
Yeah, so there's no clinical trials that have shown a benefit of bridging therapy and MDS, but most centers that on patients that have more than 10% blast will give hypomethylating agents to try and decrease that. And also, it takes, it may, if you haven't seen the patient, you don't have a donor, it may take a couple of months to get to transplant. And so it makes sense to give bridging chemotherapy. And so, a lot of these patients, but again, there's no data that have shown a benefit on bridging chemotherapy, but clinical judgment or because of those reasons, timing and most would want to cytoreduce them with hypomethylating agent for a few months to hopefully less than 10%.
Okay.
Carlos, is the TP53 mutation a factor?
We're going to get cut off in a second.
Yeah, it's bad. Yeah, and so I think those patients should still be considered for transplant. But whereas it's 30 to 50% overall survival, patients with TP53 it's only 10 to 20% with transplant. So it's much less.
Okay, we may have already been cut off. I don't know, but I want to say thank you to everybody for their participation. It was a really great discussion. Thank you guys so much for helping out and being involved.
Thank you.
Thank you very much, Jason, for coordinating this. Thank you, everybody.